When it comes to chronic pain, women tend to have more chronic pain because of hormones, right? So there's biological differences and there's also gender differences where women have more stresses in the environment and identity and all of these things that they have to deal with. So when you're trying to fix gut and you don't solve stress, it never gets better, okay? Because what's happening is anytime you stress, you have this gut-brain connection, you push cortisol into the system. It goes in there and then it wipes everything out, okay? So all the work that you're doing, if you're still stressing, you keep wiping it out. Right. People will say, oh, I woke up today and my hands are all swollen. I have no idea why my joint hurts. And I would say, go back in the last 48 hours. What did you eat? Who were you around? Even stress, right?
Hi guys, on today's episode we have Dr. Asare Christian. Dr. Christian is so interesting. He grew up in Ghana, he survived malaria, he then was Harvard-educated and Hopkins trained. He now treats patients all over the country, specializing in pain management, and taught me so much about what most doctors are getting wrong in treating patients with migraines. I learned so much in this episode, and I think you will too. Enjoy! Dr. Asare Christian, thank you so much for being here.
Thank you so much for having me. I'm honored to be here.
All the way from Pennsylvania.
Yes.
Well, welcome to sunny South Florida.
Love it.
Hopefully it's sunny while you're here. It's been very rainy lately.
Yes.
Yeah.
Yes.
But you specialize in pain management. You use a lot of regenerative medicine practices. What led you into this side of medicine?
Yeah, so kind of going back a little bit, I grew up in Ghana, in Africa, and I had a friend who died from malaria. I did not die from malaria. So that's what piqued my interest about resilience and the body's ability to heal. Wow. Why was I able to resist malaria and he did not? So I kind of had this innate understanding of the body's innate capacity to heal. So went through my training, did a conventional medicine thing for a while, and realized the limitation of that. So I wanted to kind of figure out, how I can get back to that fundamental inception of, the body's ability to heal. And that's where regenerative medicine kind of became meaningful. And that's been kind of the journey and figuring out better ways to help people to heal.
Wow, that's awesome. So when you started in medicine, were you practicing more traditional medicine and then kind of transitioned, or did you go straight into, the more regenerative side?
Yeah, so I did not, I got a little bit of exposure to regenerative medicine, but, from a conventional medicine lens, that's basically doing some injections, doing some PRP, but there is so much more in regenerative medicine when it comes to really getting people to be healthy. So when I finished residency and fellowship, I was doing physical medicine and rehab, so background in pain management, so traditional pain management, did that for a while. And then recognize, as many people make the transition, that, I wasn't really making a huge difference. People come in, we do the same injections, same medications, they keep coming back. And then I recognize that, what makes a difference is when people are healthy. When people are healthy, the medications, the injections, physical therapy, whatever it is, people get better outcomes. So the inception was, how do I figure out a way to make people healthy as a way to solve pain? So that's kind of how I shifted to starting my own practice and learning how to make people healthy. And so then, I can do the conventional stuff plus all these other things that makes people healthy. Not only is that going to improve pain, but also help with overall well-being, their metabolic health, their hormone health, all of those things that makes people's life more meaningful and, I guess, livable, vitality. That's
absolutely.
Yes.
So when someone comes into your practice, take us through the journey a little bit. Are they meeting with you immediately? Are they meeting with do you have other practitioners? No,
so I'm the only practitioner in the practice. So when people come in, they get to meet me.
Perfect.
And we talk about, why they're there. What's the problem that's going on with them. But it goes beyond just listening to them to really trying to find what is driving their current complaint.
Okay.
Specifically in pain. People, how we treat pain is we block pain signals with pain medications, okay? Right. If you have pain, painkiller. If you don't have energy, stimulant. If you don't have, whatever it is, you can't sleep, we give you sedatives. But what is driving that dysfunction becomes what I become interested in. So we focus on really understanding people's lifestyle. Those are the foundational things, because a lot of times people are not aware of what they're doing that's actually keeping them in that state of discomfort, that state of impairment. So really kind of getting into lifestyle. Okay. And then from there, really getting deep into whatever potential diagnostics that we need to do, advanced diagnostics to get us a better picture of where they are.
Okay.
And then based on their strengths and what they're looking for, we come up with a plan and kind of go from there. So it's a layered approach. We talk about lifestyle, we bring in conventional medicine things if we need to, and then get into the regenerative and some of this integrative practices also.
Is there a set of testing that you do on all of your patients, or is it completely personal to each patient?
So I have two ways of approaching it. I have people who come in and they have pain. Okay. So when somebody have pain, right away, I have to figure out a way to get rid of their pain. So that's why, we'll talk about, okay, let's do some trigger point. Let's do some injections if it's needed. But then what I do is educate people to understand I'm just blocking the pain signal. Okay. And what we have to do next is let's figure out what's driving that pain signal. And that could be a function of microbiome dysfunction, hormonal dysregulation, lifestyle, other things, and then slowly work on those things. Because if somebody comes to you and they have pain, and I'm just telling them, go eat well, go do all of these things that they know, it doesn't really solve any problems for them. So we start from there. And then I also have one approach, which is what I prefer when people are coming to see me who are interested in overall health optimization, is to do this lab called the Healthspan assessment. And it's basically a whole global look at their hormone levels, inflammatory levels, cardiometabolic, immune. So it looks at the whole person. To give us, and then it's in depth, not just like we're checking A1C, we're checking insulin, we're checking hormone IR, we're checking all these other markers that really predict when a disease will happen before it shows up.
Wow.
Right? Because people go to the doctors and, we check your glucose and it's fine, right? Insulin become dysregulated long time before diabetes show up. So the idea is to get this big picture of what's going on. And then from there, we talk about plans for lifestyle. How can you modulate your lifestyle based on this specific lab? So then it becomes more personalized, right? We also look at micronutrients as part of this assessment, hormones as part of this assessment. And then we give them a recommendation for supplements, specific supplements targeted based on their current labs, peptides recommendation, hormone recommendations, small molecules, LDN, metformin, whatever they need, and even sometimes, stem cells and other things like that. So that gives us a big picture. Right. And what I explain to people is to understand that process is there is two types of car mechanics, okay? Mm-hmm. There's one car mechanic that if your car light bulb went out, you go to them, they would just replace it and send you on your way. Mm-hmm. And then there's a second one who's going to ask the question, why is the light bulb out? Mm-hmm. Is it your wires? Is it your battery? And more importantly, it's a car. Is your transmissions working? Are your engines working? Are your brakes working? Those are the things that actually can put you at risk if they are not taken care of than just your light bulb, okay? Right. And that's just basically how we do medicine. People shows up in the doctor's office where they just get patched up. So what we do that's different is let's look at the whole system, okay? Mm-hmm. So if you come to me, I'm a pain doctor, I have elbow pain. Yes, I can fix your elbow pain, but what's going to kill you is your cardiometabolic risk. Is your insulin dysregulated? Is your cholesterol out of whack? All of those things are things that people are running around with without really becoming aware of it. They just come in and treat symptoms. So I know it's a long way to answer the question, but the idea is people come in, I want to look at the whole picture and then try to fix the whole car instead of just fixing the light bulb.
I love that. Yeah. I mean, because you're taking, like you said, if you're assessing everything from their hormones to which peptides can they benefit from, and assessing then, the acute areas and saying, would something like stem cells be of help? Even I'm sure for some people it is just the, a shot of lidocaine for short-term relief is the solution for some people.
Yes.
I love that.
Yeah. So it becomes very individualized because yes, we can solve your pain, but and I've actually seen this where people will come in and they just want to come and do hormone replacement therapy. And they're like, I don't want to go through all this assessment. I was like, that's how we do it. So let's do it. Right. And then we'll find out there's all this inflammation in their cardiac vessels. And there's like people who are actually at the verge of developing heart attack. Right. So it becomes really necessary to look at the whole person and then individualize it, obviously respecting people's value and what people care for. My goal is to meet people where they are. Not everybody's going to be, interested in all of these things that we talk about, right, in this space. So really meeting people and then providing guidance and providing that expertise to help them make better decisions. Yeah.
And is everyone's pain joint related?
So that's a great question. Okay. Pain is complex. So pain can come in the form of musculoskeletal pain, which is the joint stuff, knee pain, elbow pain, any of those things. And then there's also myofascial pain where they have diffuse pain in their back. So fibromyalgia could be one of those. There's TMJ disorders, there are migraines, there's endometriosis, there's all this different type of pain, but they all kind of have the same cellular underpinning, even though there's some variations and some other things that modulate whatever the experience is relating to that pain. So everybody coming in becomes an individualized, what is your pain? Providing pain education for people to understand what pain is, because that's the one thing that I see as a pain doctor. Most people dealing with pain don't understand what pain is. Okay, they say, I've had pain for 20 years, I've had pain and I ask them, what is your understanding of why you have this pain? And people will say, oh, it's my L4 herniation. Oh, it's something that they've seen on imaging or on their biomarkers. But pain is way more complex than that. Okay. The back L4 herniation has been fixed. You've had surgery. Why are you still in pain? So it's getting people to understand what's keeping them in pain. That's more important. What is perpetuating your pain? And that's a function of your health, which is, are you moving? Are you sleeping well? If you don't sleep well, pain doesn't get better. So really kind of meeting people where they are, providing that education, and then trying to correct the underlying imbalances that's influencing that pain. Is it hormones? Is it what they're eating? Is it a specific habit? So that becomes really getting people to connect the dots, because sometimes people don't know. People will say, oh, I woke up today and my hands are all swollen. I have no idea why my joint hurts. And then I would say, go back in the last 48 hours. What did you eat? Who were you around? Even stress, right? Certain people can trigger migraine. I talk about this, where certain co-workers was triggering somebody's migraine. People are not aware of all of these things that influence our health. So that awareness help, and then providing the solutions that are specific to them and help them to execute.
Right. Yeah. So you mentioned migraines, and I know that this is an area that you speak a lot on. I find it so interesting because I know a lot of people in my life who suffer with migraines, and with the experiences they've had, especially in conventional medicine, it's kind of one of those things that doctors are like, yeah, here's some pain medication. You just kind of have to live with this. I can't tell you the number of people that have told me, yeah, my doctor told me to drink some Pepsi. And I'm like, oh no.
No, don't do that. Yes, of course, there's caffeine in Pepsi, but there's a lot of junk in Pepsi that you don't want to deal with. So yes, migraine is really quite unfortunate that there is so many people, and it tends to affect women 3-4 times more than men. Okay.
Really?
So migraine, there's all these disparities in pain. Actually, when it comes to chronic pain, women tend to have more chronic pain because of hormones, right? So there's biological differences, and there's also gender differences, where women have more stresses in the environment and identity and all of these things that they have to deal with. So, and pain is not just a signal. There's a sensation and emotional aspect of pain. So if you've had a lot of trauma, that actually influences your pain. But coming back to migraine tends to affect women more than men. And it has multiple factors that actually influence the experience of migraine. Okay. So there's no one pathophysiology or one mechanism that drives migraine, because migraine is this complex disease where even before you have a migraine attack, 2 to 4 days before, there's all these things that are going on called prodrome, where people may have yawning, they may have some discomfort, they are not very clear. And then some people about a third of the individuals who have migraine would experience aura. Like they will have either it's vision or body sensation, and that is due to something called cortical spreading depression. Basically, there's this polarization in the brain that kind of moves around. I don't want to confuse people, but basically, if it's happening in an area that's involving your vision, that people may have some vision findings. If it ends up in a place that controls your parietal lobe, there may be some sensation loss. So there's all of these things that happens in aura. And then there's the migraine itself, where people have headaches, and then through that, they have sensitivity either to light, to sound. They can't tolerate a whole lot of things. They have to kind of shut down. And then after that, there's a postdrome, where people now have to recover. So migraine is very complex, and it's very different in individuals. There's all these genetic changes that drives all of those things. But the thing that we know about migraine that's really important for anybody who is struggling with migraine and need to understand is that it's always a trigger. There's something that triggers a migraine attack. So becoming aware of those triggers become really, really necessary. And we'll talk about treatment, but really the point that needs to be made here is emotional stress. We've studied individuals who have migraine. Emotional stress is like number one.
The number one trigger
for migraines for a lot of people that were studied.
Is emotional stress.
It's emotional stress. So figuring that out is important. Okay. When people don't eat, there's energy imbalances, so that can also trigger it. Alcohol, certain foods, hormonal changes, people going through menses. In fact, there's menstrual related migraine. So all of those triggers become very important. And the point is that there are solutions. It's not just medications, because what we have in migraine, or how we treat migraine in the past, is taking something that blocks the migraine when you have it, which is the abortive therapy. And we used to use medications called triptans. And they tend to cause vasoconstriction, so they are kind of restricted. And sometimes they just knock people out and people can't really function. And then we have preventative therapies. And traditionally, what we use for preventative medicines for migraines were antidepressants, anticonvulsants, and antidepressants.
Wait, antidepressants twice?
So anticonvulsants. So this is medicines for seizures. Seizure medicines, depression medicines, and blood pressure medicines.
And blood pressure medicines. Okay.
So this is the medicine we're giving to people, and people still take that. People are taking topiramate or Topamax to prevent migraine, but they all have a lot of side effects. 80% of the people who take this medicine have to stop it because of side effects. So, and then people are stuck with that. They don't have any other options. And then now we have some new medicines called CGRP antagonists. So I don't know if you've heard of those. So those are new medicines that are actually specifically designed for migraine attacks.
Oh, okay.
Previously, we were using the other medicine, the blood pressure, the seizure medicines, the antidepressants.
You're using other things off-label.
Off-label, because there was no one mechanism that explains migraine. There's multiple things. Why is a blood pressure medicine working for migraine? Why is an antidepressant working? Because there's all of these things. And would that
be because the blood pressure, the high blood pressure is causing the migraine, or the depression is causing the migraine?
Not necessarily.
Okay.
It's just the mechanism. And basically what those medicines are doing, it's not really going to the root cause.
Right.
It's basically trying to block a symptom. Okay. So what antidepressants do, or depressant medication, is they block sodium channel and they also block calcium channel. So they slow how the symptom, the pain propagation is to the brain. Okay. So it's blocking the symptoms of pain. Blood pressure medicine. So one of the concepts in migraine is that people have vasoconstriction. The blood vessels around the meninges constrict as part of the pathophysiology. So we give you medicine that relaxes it. So that's the kind of way to do it. Okay. And then the anti-seizure medicine, also the same thing. They block sodium channel, which is how pain gets processed in the brain. So those medicines were just treating the symptoms. But what's driving that is a function of people's stress response, the microbiome, what else, hormonal changes, smell. There's all of these things that people need to become aware of. So then when you're aware of those things, then you can actually block it before you have to take a blood pressure medication.
Okay. So I have a few questions. One, you mentioned a few minutes ago that trauma can affect the way we experience pain.
Yes.
Can you explain that, like, for dummies? Because I think that's really important. I think so many of us, whether it's big T trauma or small T trauma, have experienced some sort of trauma, and we don't necessarily correlate it with physical pain we might feel.
Absolutely. So that's an important concept for people that are dealing with chronic pain or any pain to understand, okay? Because in a simplistic terms, when you have pain, pain is a signal, okay? So pain is a signal. So let's just say you cut yourself. There is some inflammation that happens here, and then your cells will take that information to your nerves, and that goes all the way to your spinal cord, and it goes all the way to your brain, okay? And then your brain will tell you it hurts, it feels this way, it's achy, it's all of those things, okay? Until that signal gets to the brain, you don't feel pain, okay? And then when that signal is also going to the brain, there is two things that are happening. There's the signal, and there's two pathways. There's an emotional pathway, and there's a sensation pathway, okay? And the reason why we have those two pathways with emotion and sensation is that pain is a protective mechanism. Right? So when you step on something hot, you touch something hot, you always remember not to do it again. Okay. Why do you remember? Because there's that emotional pathway, and emotion crystallized memory. Okay. Same thing happens with trauma. So when you have a trauma attack, there's this emotional thing that happens, and then that get crystallized, and that makes your brain hyperactive or on the edge not to forget. Okay. So when pain signal gets to the brain, and the brain have to interpret that signal, it has to make that interpretation in the context of, am I safe? Okay. And even in a more simplistic terms, pain is basically a signal plus fear. Okay.
Pain is a signal plus fear.
If you take away the fear, it's just like a sensation. Because when people have pain, they go, what's wrong? Am I dying? Do I have cancer? You know, so anytime you have pain and you can't explain it, your brain is going like,
It's causing like emotional distress.
It's causing emotional distress because like, what is happening here? This is not normal. Okay.
It's trying to solve.
Exactly. Okay. So when people have had trauma, it makes their nervous system or the brain interpretation of any signal a little bit on the edge. Okay. So when you have people that have had trauma, they tend to have pain where their system is making that interpretation so big. So for example, if there's a small signal like this that's coming to the brain, the brain seeing that signal as this. Okay. So something very small, yet it's perceived that, oh my God, this is really, really painful. Okay. And the other thing that people who've also had trauma need to recognize is that that signal that's coming to your brain, sometimes this can stop and the brain itself can create that signal. Okay. It's called neuroplasticity. So the brain learns pain. And an example, maybe it may not be as clear, but an example that I give people is like, we can cut off people's leg.
Yeah.
The leg is not there.
Yeah.
But they can still feel pain.
Yeah, they have the phantom pain. Okay.
So pain is always an output from the brain.
Okay.
So when the brain have had trauma, then in the context of how it's interpreting pain signal, it makes it more scary. And then you experience more pain. Okay. So people with trauma need to work on that as part of getting the brain to calm down. So even when you have the pain, the brain doesn't blow it up and it's just seen as a small signal and making you feel safe.
Okay. That makes a lot of sense. And would working on that be like doing cognitive behavioral therapy? Are there technologies? Like I know there are like would a vagus nerve stimulator be relevant here?
Yes, absolutely. And part of one of the problems we have with so many people in America having pain, we have more than 25% of the population with chronic pain.
Right.
And the problem is that when we are treating pain, we just treat pain through the lens of orthopedics. Your MRI, your x-rays, we give you injections, that's it. But it's so important when people have chronic pain to also work on the brain. So the very concept you're talking about, CBT, cognitive behavior therapy, something called pain reprocessing therapy. All my patients that I see who have chronic pain, I give them this app that actually educate them about the neuroscience of pain. Okay? So when people can feel safe, then it's actually a sensation. People are afraid to bend over. People are afraid to do all of these things because when you think about it, even before you do that action, your brain, because if you're in fear, the brain creates the corresponding chemistry. I have people that will not bend over. They're afraid. Okay?
Right.
And we've actually done studies where we put people in an MRI, people who have back pain, and we say, just close your eyes, imagine yourself bending over to pick a piece of paper. They're not doing that action, but the brain thinking about that alone creates pain that we can measure on MRI in their body and everything tenses up. Okay. So the brain is really powerful in modulating how we experience pain and how we experience chemistry. So those things are important. CBT, pain reprocessing therapy, all of those things help to calm the nervous system. Part of that process is potentially using some modulation, such as, vagus nerve stimulator to calm down the sympathetic aspect of things, and breath work and mindfulness. All of those things are important in pain. So we got to work on the brain and we got to work on what's happening in the periphery, whether it's a function of inflammation from the gut and other hormonal things. All of that has to be put in place to get people to actually get out of pain.
Okay. So for a lot of those things, are you referring out? Are there technologies in your office in terms of like rewiring the brain?
Yes.
Are you doing some of that in your office as well?
So I provide basic education on that, and then I give them this app called Curable. And Curable is an app that really, it's all about rewiring the brain. So it's basically neuroplasticity. The brain has learned pain, and we can also get the brain to unlearn the pain.
Okay.
It's the same thing. The cells have learned pain. We can get the cells to unlearn the pain.
You mentioned how much hormones can influence pain. And I'm a woman. I've experienced that, when I've had PCOS and hypothyroidism and mast cell activation syndrome. And when any of those, symptoms or when any of those conditions are flaring, I have experienced a severe headache.
Yeah.
Right? So for a cycling woman, I want to talk about first, and then we'll talk about the stages of menopause and how that can affect. But for a cycling woman, what are some treatment options you've explored to help mitigate, because it can be migraines can be a common symptom of PMS, right?
Yep. Yes. And that's an important thing for us to talk about, because in conventional pain management, we don't talk about the role of hormones.
Right.
In pain processing and pain modulation. Hormones play such a huge role in how we experience pain.
Right.
And that is why actually women have more pain than men. Okay. And we'll get back to the cyclic and all of those things. But one of the things that people need to understand, so high estrogen is protective against pain. Low or fluctuating levels of estrogen can either increase your pain or decrease your pain. And we'll talk about what that means. Progesterone, testosterone, all of those are pain protecting. Okay.
Progesterone and testosterone are pain protective.
Yes, they are all anti-inflammatory, so they help to reduce pain. Okay.
And estrogen
is the one that it does its own thing. At a higher level, it can protect your pain. At a fluctuating level, it can increase or decrease in pain.
So if it's dropping or rising,
that's when we have an issue with it. Okay. So for individuals that are cycling, going through, the 20s and 30s, and they're having monthly cycles, people go through pain, every cycle. Okay. Right. So what I do for my patient is we have this drop in estrogen that's going to happen. So when those times are coming, we talked about how do we optimize and buffer the whole system? So for example, somebody who have migraine, this is a time that we want to dial in sleep. This is a time we don't eat junk. This is a time we're not drinking alcohol. This is a time that we're hydrating. So then you can kind of give your body the resilience to be able to kind of adjust, okay? Because it's all about resilience. You can drop estrogen, but if your physiology, if your body can sustain and control inflammation better because you're not eating junk, because you're not stressed, because you're sleeping well, then you may not have as pain, okay? And then sometimes what I do is I can also put people on supplements. I have a few individuals with migraines that get it cyclically, where we would talk about, okay, take this towards that time, take these supplements and magnesium and some other thing that stabilize stress response. And people are able to manage with that. So I've not gone to the extreme of using hormones at that, cycle, but really kind of the lifestyle fundamentals. Let's not do too much during that time. Okay. When it gets to perimenopause, this is where everything is erratic, right? Because the cycle, estrogen, progesterone, everything is going up and down and it's all over the place. And that's where it becomes a little tricky. So this is where potentially we can kind of, try to balance hormone out. If there's a need for bioidentical hormone replacement, we can put people who have a lot of symptoms, we can put them on specific therapies that helps to kind of stabilize. Postmenopausal, people lose estrogen, so then they lose the protective benefit from inflammation, they lose the protective benefit for bone health, they lose protective benefit for cardiovascular health. So that also becomes, how do we optimize those individuals also, not just for their pain, but also to get them to actually, become overall healthy. And one of the things that is also important with migraine is that we now know that when you withdraw estrogen, it actually increases something called CGRP. So CGRP is calcitonin gene-related peptide. It's a peptide that is released in migraine. We know that happens in migraine. That actually leads to the experience of migraine. So a lot of the new medicines that we have that is very specific for migraine target CGRP. And CGRP, calcitonin gene. So Ubrevy, I don't know if you heard of any of those medicines, but people that have migraine, there's all of this new class of medicines, and they are all based on that. And estrogen affects that. Okay.
Oh, that's so interesting.
Yes. So that is things that, people need to understand. So I think if you are young, the idea is how do you provide a buffer by being as healthy during those times? Magnesium, other supplements, other things. I don't know if we can talk about those things. But
I was going to say
things can really help with those things.
So back to like a woman of a cycling age, and then we'll get back to menopausal women. But so you mentioned magnesium.
Yes.
Are you using anti-inflammatories like turmeric, or what else are you using?
So we're using omega-3s, using turmeric. Those are great. And then also a lot of adaptogens, because the stress create pro-inflammatory chemistry. So stress will make more inflammation. So I put them something that relaxes them.
Like an ashwagandha?
Rhodiola, any of those things. And then definitely magnesium is a great one because, in fact, one of the theories that we know drives migraine is called the metabolic theory. And you have this ATP creatinine phosphate system that makes energy. So one of the theories, I'll go that briefly, is that the reason why migraine happens is that your brain is very energy intense, right? The brain uses a lot of energy. When there's any drop in that energy, that can trigger a migraine, okay? And then at the cellular level, you have this system that makes energy very fast. So that when people are taking creatine, it's this, ATP creatine. But that pathway requires magnesium as a cofactor. So when people don't have that, they can drop. Okay, so magnesium is a great one to help with migraine.
Which type of magnesium? Because
I know there's so many of them.
Citrate, and it's like, you need to poop, take this. You need to relax, take this.
So glycinate is a good one because L-theanine is also a good one. And then malate is actually very good for muscle, okay? So the citrate and oxide tend to be more gut related, and people can have diarrhea from that. So if you have to pick one, I would say do magnesium glycinate. That's a good one and simple to do. Okay.
So that shouldn't disrupt your gut. It should help relax the body.
It should help relax muscle. It should help with pain. It should help with sleep, and it doesn't do any of those issues. Other supplements that people can also explore are B vitamins. So riboflavin is a good one. CoQ10 can be explored. There is also butterbur. There's specific, and these are all
butterbur.
Yes. Have you heard of it?
No.
Okay, so it's a plant molecule.
Sounds like butterbeer.
Yeah, it's butterbeer, but butterbur is a little different. So it's not beer. Those are all been studied to really help with migraine prevention.
Interesting.
And don't have the same side effect that you have from a triptans or from an antidepressant. Sometimes they have limitations. So those are the things that I try to educate people to do in the 20 cycling place. Postmenopause. In fact, in postmenopause, some women actually migraine goes away. That fluctuating levels kind of
because the fluctuation
stops. So they don't have it anymore. And then you also have people who have more pain because now they are estrogen deficient, and estrogen is anti-inflammatory. There's even more arthritis. People start having more pain in their joint and they go, I'm getting old.
Right.
It's estrogen deficiency.
Okay. So let's say we're perimenopausal, which means menopause is starting. Your cycle's becoming irregular.
Yeah.
Your estrogen, your progesterone dips first, correct? And then it usually is followed by estrogen and testosterone. And this can usually be, it can be as early as late 30s. It can be as late as early 50s, correct?
Yes.
Is hormone replacement therapy the first line of action here?
So it depends what kind of symptoms people are having. And it also becomes an individual thing. Okay. So if somebody is going through that, we know, so how I look at hormones is we use hormone therapy for prevention of disease and also for symptom control. Okay. So conventionally, people are like, okay, we're treating your symptoms. If you're not having hot flashes, if you're not having this, we don't need to give you any hormones. Okay.
Right.
So, but we're on the side of, okay, what are your risk factors? Right. So if I have somebody who is thin, they already have a risk of potentially developing osteoporosis, osteopenia, all of these things that goes wrong, cardiovascular risk, family history. So this is somebody that we're going to have the discussion and say, hey, your hormones are kind of dipping. It's not all the way down yet. You're still making some. Is there a way to kind of stabilize things where we are maintaining or preventing symptoms? And then this is also being preventative because we know it's protective for pain. It's protective for bones. It's protective for cardiometabolic health. So it becomes having that discussion with that individual. And again, it's all with all of this therapy because of this confusion about hormones, but hormones are very safe. Okay. We know that. So it's really having that discussion with people, getting them to understand what are the benefits? Right. And then if they want to approach that way, then we start from there where sometimes I would just start with testosterone. Testosterone is actually a good one to modulate pain. Okay. And you also take testosterone and make estradiol. So sometimes just getting people a little bit of testosterone alone helps to balance everything out and kind of go from there. And if somebody needs estradiol, we can do that. Sometimes we can do just a localized vaginal application, which doesn't have the systemic potential risk that people would tend to worry about. So it becomes very individualized. But having the discussion about what are your symptoms and what are your health goals and what do you want to prevent in the future. Okay.
And then it would be similar, or would you say that all women, so once your cycle has completely stopped, that's when you're officially menopausal, correct?
Yes, a year after that. Yes.
A year after that?
Yep.
And would you say, as a general rule, no cancer history, no personal cancer history, you recommend most women get on hormone replacement therapy of some degree?
Yes. And, as a physician, where I'm coming from with that is to prevent disease.
Right.
Because we had this mindset of treating sickness. We wait till people develop osteoporosis. We wait till people develop osteopenia. We wait till people develop cardiac disease. And then we go, you need this. Okay. And in fact, estrogen is FDA approved for osteoporosis prevention. Okay. You can also treat it. But so the idea becomes having the discussion to say, hey, we want to optimize life. I'm a longevity medicine physician now. So I care about all of this disease that happens in our lives goes up as we age. If we can slow those things down, and I think there's no best. And people can argue about this, but in my opinion, and from what I've seen, there's no better anti-aging agent than hormones. Okay.
Really?
Yes. Hormones.
Say that again.
There is no better anti-aging agent than sex hormones.
Yeah.
Okay. Sex hormones does everything.
Yeah.
Okay. Improve your bone health, muscle health. If you don't have muscle, you develop sarcopenia, osteopenia, osteoporosis. What kills women the most? Hip fractures.
Right.
Okay.
You age rapidly.
Exactly.
If you don't have muscle, you age rapidly.
Right? Because you don't have the capacity to modulate insulin and glucose. That is really important for overall health. It also is involved in cardiovascular disease. It's inflammation, right? Inflammation drives all disease. Senescence, the concept that leads to disease, is all of those things are modulated by sex hormones. So really, I think the discussion now have to shift, but it's all about risk stratification, right? It's not everybody. Hormones don't cause cancer. If you have cancer or if you have some potential risk or genetic predisposition, then, estrogen. But it's all about balance, right? Estrogen makes things grow. Progesterone balances that. Testosterone balances that. And I think it's, individualizing it. But I do tend to recommend that people explore that as a way to prevent disease because we don't want to wait. We know it's going to happen. It's not changing. Yep.
And the reason you're saying it's preventative is because if somebody is living with their hormones bottomed out, they're at higher risk of disease for that reason.
Absolutely. Yeah.
Okay. Yeah. It's not only you're not going to be able to keep the muscle on, you're not going to be able to control your blood sugar, but it's literally if you're living and your estrogen is way down here you don't have all of those other protective mechanisms that are going to protect you against cancer and other diseases.
Absolutely, because it's immune modulatory. So like
Right.
the hormones are like the knob on all of this, like immune function and inflammation. You're talking about PCOS, having PCOS and having
Right.
pain.
Right.
So part of that is the hormones, right?
Right.
Because in PCOS, you have this insulin sensitivity, that high insulin that creates that you have androgens that are high, and then you tend to have low progesterone. Okay,
Right.
so you lose that. So you lose all of those protections, and then
Right.
you have more inflammation. So, and then the other thing that's also important is that not only those things, but it's also about quality of life, right?
Right.
When people don't have hormones, they feel crappy, they feel
Right.
depressed, they can't sleep. And what happens? We put them on antidepressants.
Mm-hmm.
We put them on sleep medications.
Mm-hmm.
And then we put them on pain medications, okay?
Mhm.
And that's all because of deficiency in estrogen or progesterone. People just need progesterone to be able to sleep.
Right.
But then they get put on 3 medicines. So it's really about improving people's quality of life. People can't think very well, brain health.
Mm-hmm.
And in fact, there was recently a study that looked at Alzheimer's in women who've gone through hormonal therapy. And it turns out that when people start hormone therapy for women earlier, it's actually protective against Alzheimer's. Okay.
Really?
So
Yeah.
it's kind of having a different lens of, how do we use this? Now we know this is very safe in the right person.
Right.
And then you have to also go to the right provider who understand the nuances. There's all these nuances, there's changes in literature. So people have to be up to date on those things
Right.
and provide better education. And then ultimately, for me as a physician, it's not about me, it's about the person who's in front of me.
Right.
What do people value? What do people care for? And then I just provide that education. But I think this is something that we need to talk more about to get people to understand that we are trying to even use this to prevent disease. We are now
Right.
waiting, the medicine is changing. Longevity medicine is like, let's prevent the disease. Whereas conventional medicine is like, okay, let's solve it when it gets there. Okay. And it's hard to do when it gets there.
Yes. And then are you using GLP-1s in the same way?
Yeah, so I'm glad that we're talking about GLP-1s, and I love GLP-1s. I mean, as a pain doctor, that's probably one of my best peptide. Okay, if you have to ask me what is my favorite peptide, it would be GLP-1.
Yeah,
because
we talk a lot about GLP-1s here, and I talk a lot about my experience with them. They helped me a lot with controlling the inflammation because PCOS and MCAS. Unfortunately, I'm not on them anymore because I want to get pregnant soon.
Yep.
But just I felt so balanced, not only in did this excessive water weight that I tend to hold come down, but even in my brain. So when you were talking about the fact that pain is so related with your brain, I'm like, yeah, I had no headaches. And not even just physically, I felt more mentally just stable.
Absolutely.
My energy didn't have these highs and lows. I just felt like I was living in the middle and I was just so much more stable.
Yeah.
And I talk to a lot of people that feel that way. It's you're able to focus better. And I do notice, like, when I'm not on it, I do have, little joint pains here and there that I was like, you don't even realize you don't have those anymore. You don't have the achy hands.
Yep. So that's an excellent observation, because that's actually, I was using GLP-1s to treat pain, not for weight loss. Okay. Because it's anti-inflammatory.
And are you using them, if you're not using them for weight loss, are you using small doses?
Small doses. Okay.
So, and would you mind sharing what is like a starting dose you typically start with for a patient? Obviously, it's different for everyone.
It's different for everyone. So when I'm doing that for people that are trying to, specifically for pain modulation, we start with an in-body, so understand the body composition, okay?
Right.
Because even at a smaller dose, for some people, they start losing weight. And so you start with that to understand and monitor them as you go along.
Okay.
And what I do is microdosing, okay? And what is microdosing? So microdosing in my lens is the quarter of the dose of the lowest FDA approved dose. Okay. So whatever the FDA approved, I go a little bit lower, and then we start from there, and it becomes, okay, is this helping? And then, in fact, I'm going to be talking about this at longevity first. Yes, I'm talking about GLP-1s and pain.
Okay.
And
in Vegas?
In Vegas.
Oh,
yes.
great. Okay.
In December. So there is specific dosing. We haven't really come up with a dose yet that can be used for pain, but there's a lot of studies that are looking at arthritis and all of this, and because it modulates inflammation, and then it modulates metabolism. Our cells, we're made up of all the cells, and how the cell function is energy. And if anything that you have that helps the body to make better decision about how it's modulating energy, insulin, and all of these things, and it's not creating a whole bunch of reactive oxygen species, the whole system works well. Okay. So there's all this pleiotropic benefit from GLP-1s, from brain health. In fact, it was initially designed to treat Alzheimer's, and then they figure out, okay, we can use it for diabetes and all of these things. So
really,
yeah, so that was the initial concept. Yeah.
Okay, I knew that we had discovered its effect with Alzheimer's I thought it was more recently, though. I didn't realize it started.
It was kind of, that's where it started. But, of course, figure out where do you make the most impact. A lot of people have metabolic issues in America, right?
Sense. Yeah.
So it works on lipids. It works on metabolic syndrome. It works on same thing. I had a patient who has PCOS. This is, who followed me. I was just treating her for migraines. I was doing Botox for migraines for her. And she came to my new practice and I learned about peptides. And I was able to treat her PCOS, not just her pain. So really, I always feel so privileged and so blessed that I got into this space because I can do so much more for my patients. Because now I have a broader lens of assessment. I'm not just blocking pain signal. I'm looking at the cellular dysregulation that's creating that pathology.
Right.
And what is it? It's this. It's hormones. It's all of those things. So same thing, GLP-1. Talk to people about what it is, how does it work, how to mitigate risk and side effect. Everything that we do in medicine have side effect. And I think sometimes it becomes unfortunate. People don't really get the education they need and don't use specific therapies in the right context specifically for them. So then they develop side effect and they think everybody experiences that. Okay. So really it's about getting to somebody who understands all of those things. But GLP-1s are great and it becomes the same thing, individualized, and I think, even now we know like there's studies that shows that it actually helps improve biological age. Right. So in the longevity space, we talk about this is going to be one of those drugs that we're going to use as an anti-aging because it is anti-aging. It actually extends lifespan.
Right, right. So it would be hormones and GLP-1s usually used together for people in their 40s, 50s, 60s, 70s. Can be, that's what we've seen. It's like this magic duo.
Absolutely.
That really, once again, it helps kind of stabilize people. Their pain is reduced. Their energy is kind of stabilized. What other peptides are you using for pain?
So I like GLP-1s as a starting place. And even, going to those peptides, the thing that's also great about GLP-1s is even getting people to make better choices. It also works on the hypothalamus, right? So it makes people to pause and go, do I want this bite? I don't. Do I need this cigarette? I've had people stop drinking, people stop smoking just because it kind of slow things for them. Yeah. So it has a lot of benefit. And I love that you guys do the same thing, combining that with hormones, right? So women, it's hard to build muscle. So somebody's on GLP-1. We put on some CJC epimorelin. We put on some testosterone. Right. It's magical.
So CJC epimorelin, for those that don't know, it's a growth hormone peptide.
Growth hormone releasing peptide, growth hormone releasing hormone, yes.
So different than putting someone on growth hormone.
It is very different. It's not the same. Yeah, so this is a peptide. Right. Okay? And then you asked me about some peptides for pain. So I like, everybody talks about BPC 157. Right. Okay, my experience with it, it's good, but I don't see that it's not a good analgesic. So there's certain things that helps heal, but don't block pain signal. Right. So now there's a new version of it called PDA. So that's the version that you can get now, and it has an arginate attached to it. So it's very good for pain. Okay. I also like thymosin alpha-1, thymosin beta-4. I like some of those gut-related peptides.
Those would all be... Like if you have an acute injury that's causing pain, it'll help your body heal. Yes. But like you're saying, it's not necessarily going to help block the pain. You're going to be in less pain because your body's healing.
Your body's healing, yes. Okay. So, and that's an important concept in pain management because, and sometimes even in this regenerative space, yes, you can give things that's going to let the body heal, but you also want to block pain signal. Right. Okay. So there's a place for blocking pain signal because the problem is that when that signal gets to the brain, and there is a corresponding signal from your brain to the muscle. So when you're in pain, your muscles get inhibited. So you're not moving as well, and then people compensate. Okay. So that's for me as a physical medicine rehab doctor. It's all about really let's get people to not create secondary complications. Right. People are compensating, and then next time they know they have another pain somewhere else because they're trying to protect this knee. Right. Okay. So I like to get ahead of let's get rid of the pain. Let's do everything else that allows the body to heal. If getting rid of the pain kind of inhibits that whole healing cascade, we have to find a balance between that. Okay. Right. And I was actually, before I came here, I was just talking to a friend who just sprained his ankle, and he's an actor and he's busy and he's a young person. And I was like, okay, I'm not a fan of ibuprofen, but with your work and the contest and what you're doing, get on ibuprofen, 600 milligrams, take it 3 times a day, take it with food. It's quantifying his risk. He's not taking it for days. Okay. That we're going to get rid of the pain so then he doesn't compensate and create more problem as an actor who's doing action things. Okay. So it becomes very specific. So we can use peptides to really help the body to heal, to regenerate. And as part of that process, pain gets better. But sometimes, we need to try to bring the pain signal down to help with that process.
What about low-dose naltrexone? Are you ever using that?
Yes, I love low-dose naltrexone. I think everybody should be on it. Yes.
You think everyone should be on it?
I think everyone should be on it.
Okay, so GLP-1s, hormones, and low-dose naltrexone.
Yes.
Okay.
Why?
Tell me more.
Because low-dose naltrexone, especially from a pain doctor, mechanism of action is immune modulatory, okay?
Okay.
It doesn't suppress your immune system. It gives the immune system the signal it knows to know when to go up, when to come down, right?
And can you explain what naltrexone is and what it was traditionally used for?
Yeah, so naltrexone is actually a medicine that we use at a higher dose to treat opioid use disorder.
Right.
Or alcohol use
addicts.
disorder. Addicts, yep.
So addicts use naltrexone to kind of block the craving in the brain.
Craving,
right?
Exactly. But at a higher dose.
Right.
So in fact, when I'm talking about, recommending that for people will think, oh, do I have a problem? It's like, no, that's not what we're doing. So low dose is different. So low dose is from 0.5 or even 0.25 to about 4.5 milligrams. And then there's some variations that people can do. It's immune modulatory.
Okay.
So modulating immune system is super, super helpful for overall health. Okay. It's also anti-inflammatory.
Okay.
It controls inflammation in a healthy way.
Okay.
It's different from ibuprofen. When we use an ibuprofen, we're blocking these two pathways that controls the pain as well as the healing cascade. Okay. So we want to block just the inflammation part of the pain producing inflammation part of it and not the healing cascade. So LDN just block the bad side of things. Okay. And then it also blocks your own endogenous opioids because we use it for opioid. It blocks your body a little bit. So then your brain thinks you don't have enough of it and your brain makes more opioid because the brain and the body makes its own opioid to control pain. Okay. So your body is making its own opioid to control pain. Its immune system is being modulated in a healthy way. And then it's also anti-inflammatory. And then what drives every disease state? Oxidative stress, immune dysregulation, and inflammation. Okay. So those three things are all things that can be modulated with LDN, GLP-1s, that's the same, hormones, that's the same.
I was going to say, so is it working similarly to GLP-1s in the way that, like we're saying it, on a GLP-1, a lot of people say like, I not only don't need to eat the extra dessert, but I also don't need to smoke the cigarette, drink the extra glass of wine, go on a shopping spree. It's kind of mitigating that. Is low-dose naltrexone working similarly?
Not necessarily, because, GLP-1s is kind of like, it's also working on the brain to kind of, but the naltrexone at a higher dose is what prevent that. But the low dose doesn't have that, type of thing. And the main thing that people have to watch out for is like, if you're going to be drinking a whole lot, if you're going to be taking opioids, then you have to stop taking your low-dose naltrexone, okay?
Why?
Because it blocks opioids. So for example, you've had surgery, and you're on low-dose naltrexone and they have to give you maybe, whatever, Percocet or whatever for a few days, you don't want to be taking low-dose naltrexone because it's just going to block it. So basically, it's not going to work. It's not going to work. Yeah. So that's the context of how to use it. Yeah.
So interesting. And then I had mentioned earlier, I've had MCAS as well.
Yep.
And something I noticed with MCAS, so I had gotten it after having a severe virus and just like it was the week of my wedding. I got this virus and then I had my wedding. It was kind of this like peak of stress physical and emotional all at once. And then I had this like rebound where I just felt like my mast cells have just gone crazy. And in that, I would wake up a lot of mornings with neck pain. And I found I had to be really careful working out because I was pulling muscles in my back like left and right.
Yes.
Why is that?
So when you have activation of your immune system, okay? So when you have activation of your immune system, the immune system become hyperactive. It's trying to like protect you. But then so when you stress, for example, you put any ligament or any tendon, anything like that in your body, like you're exercising and you pull those things. If a little fragment breaks off from a tendon, your immune system see it as antigenic. Immune system see it as something that's foreign. Okay. So what it does is in a state of dysregulated immune function where everything is hyper, any of those things that shows up in your body becomes a target for trying to heal it but not healing in a healthy way. So it just goes and attacks it, trying to heal it, but then it creates more inflammation and it creates more pain.
It's like overcompensating.
It's overcompensating. It's not doing it right. Basically, like we need the immune cell is there to kind of control things in a structured way. But when it doesn't have the right signal, when it doesn't have the right information, or the right energy, mitochondrial dysfunction, all of those things, so it doesn't have the right energy, then it's just doing it some hazard way, and that's what we end up with, problems that people experience as pain or fatigue and some of the things that we talk about.
Oh yeah, the fatigue has been crazy.
Yeah.
So do you use, like, would peptides be your go-to for that, for regulating MCAS, or what's typically your go-to there?
Yeah, so I think, there's different ways you can look at that. So part of it is really getting people to get away from the offending agent. Sometimes it's hard. Stress, modulate, affect your immune system, everything else, okay?
Right.
And then the gut plays, the microbiome plays such a huge role. And in fact, we didn't talk about that, but pain, as a pain doctor, one of the concepts I've really come to appreciate is how much the gut influence immune activity, okay? So your T regulatory cells, these cells that will kind of modulate all this immune activities in your body, they're all modulated in the gut, okay? So one, we try to fix the gut. We try to talk about, let's avoid anything that's potentially going to create more immune response from a gut standpoint. We can talk about peptides that are very good for immune modulating. So this is where thymosin alpha-1, thymolene could be helpful. Lorazepatide is also a peptide for the gut that can help kind of stabilize things. Okay.
And would you do all of those oral to go into the digestive?
Lorazepatide is an oral, which is a good one. Thymosin alpha-1 it's an injectable, so injectable. It still works. It works. It works really well. Thymosin beta-4 is actually also very good for the stomach, also. Okay. So that can also help. So all of those immune peptides could be helpful.
Okay.
Lifestyle. Let's make sure we're not eating anything that potentially may trigger this. So gluten, back away from gluten, back away from anything that's inflammatory in nature.
Right.
Getting people to sleep well. Okay. Yeah. So kind of dialing all of those lifestyle in, and then we can bring in the supplementation, the LDN, the peptides to kind of help everything to stabilize.
Right.
So that would be the approach of how I would deal with that. Yep.
Okay.
How did you deal with yours? Was there a way? How did you manage it?
I've tried everything. What has made the biggest difference for me is taking Peptide in the morning and at night. Famotidine. Yeah. That made the biggest. I didn't sleep through the night for a year. Like I was like my heart rate was just going crazy all the time, and I think Dr. Davis. He was the one that gave me the diagnosis of it, and it was because he was like, "Do you sneeze after you get out of the shower?" And I was like, "Yeah." He was like, "You have MS." Yeah. And it was something that I've been dealing with in a very acute way for the last almost 2 years. But I've had this. It's kind of been correlated with my PCOS all along. Like when I was 16. My family would joke that I was allergic to getting up early because I would wake up and sneeze and have a runny nose and just be super congested in the mornings. I took Claritin D to go to school almost every day for my junior and senior year of high school. Yep. We didn't know what it was. I got allergy tested, and I've always been very sensitive to sugar with it. Like if I eat sugar,
it's inflammatory. You get worse. Yeah.
So and gluten. Now I'm totally gluten free, but especially if sugar is with dairy. It's especially
all the fun stuff. All the fun stuff. You can't have them. Yes.
I know. And now wine. I love wine, and like, my husband asked me last night. He's like, "Can we drink some wine this weekend?" I was like, I could take some extra antihistamines if you really want to.
It's balance. It's all about balance. You do all the other things well. You exercise and you're sleeping well, and that's what I talk to people. I mean, it's in this space of longevity, people tend to be very strict, but the people that are living longer, they are actually, they like to have fun, and they drink and they do all of these things. And what gives them, it's all about resilience, okay? Yes. So if you're doing all the other things right, if you're sleeping well, and if you exercising, and if you're eating well, if there's, 20% of the time, because the body also needs a little bit of stress, okay? Right. The idea is not to shunt away from everything. Right. Otherwise, you lose the resilience, okay? Right. So resilience. Prerequisite for that is adversity. So a lot of stress, and we talk about hermetic principles, things that a lot of stress the system, the same thing, sauna, all of these things that we do, they are all stressing the cells in some level that's healthy to kind of get it to be better. So a little bit of exposure is fine there. Yeah. But I would say even for you to think about, we can talk offline about some other ideas that could be helpful for, and it's really just dialing in the gut health, microbiome stuff, and that can help with that also.
Yeah, dialing in the gut health has been very important. I actually I started working with, because MCAS is I had never heard of it prior to being diagnosed with it, right? Yeah. And it's funny because, the more you look into it, and especially over the last year and a half, it's become a little bit more prominent, especially in, our industry. Yeah. I think coming out of this age of COVID, I've spoken with a lot of patients who they get either COVID or the vaccine, and they have this aftermath effect, and they can't fully pinpoint what it is. And it's funny because I went through the same journey. I was like, I think I have mold toxicity. And, it was Dr. Davis was like, only drink, organic, mold tested coffee, and we went through all of that. I got the office tested and everything, and I did have a little bit of mold. I think everybody does.
We are supposed to wait, yes.
Right, but it's funny. It kind of triggered all these things. And I've spoken with a lot of patients who are going through the same thing, and it seems to really be about stabilizing. And now I'm really focused on gut health for a long time I was on a lot of like antimicrobials like berberine and a lot of herbs like that. And now I've just shifted off of those and I'm just on things just trying to build the gut. Like glutamine and glycine. And that's why I was wondering about oral peptides, because I'm thinking of maybe doing like an oral BPC 157 and KPV.
Yes, KPV, BPC. Those are great. Lorazepam is also a great one for the gut.
I'm going to look into lorazepam.
And then even thymosin beta 4 for the gut is amazing. Yeah. How was your experience with MCAS when you were on the GLP-1s? Did that improve?
It was great. Yeah.
Yes.
It really helped.
That's the one thing I was just like, because that anti-inflammatory benefit and then modulating the cells to become better. Okay. So your cells have all this intelligence to adapt in a healthy way, not to be so hyperactive when it has the right signal. Right. And that signal is the energy state of the cell. Okay. So GLP-1s help with the energy state of the cell. The cell can make better decisions and then it can control inflammation better. So
yeah. And one of the symptoms I really experience is, and I didn't realize how abnormal it was until I didn't feel it, was how reactive my body is to everything that I eat, and how like I really don't get fullness signals like most people do. Like I'm like I have to have this like mental conversation with myself now of like, okay, you've eaten a good amount of food.
That's enough.
You should be full. You need to stop.
Yeah.
As opposed to my body just being like, okay, we're good, you know?
Yep.
And even just like I noticed I was eating very low carb and then craving a lot of sugar because I hadn't eaten carbs all day. But because my body has this kind of inflammatory response where I feel I hold a lot of water weight when I eat carbs. I feel like I kind of just like bloat up.
Yeah.
And yeah, it feels like a dysregulated cell response.
That's exactly what it is. And then I think one of the things that I also want people to get across is like when you're on GLP-1s, one of the things that I stress with my patient is like, use that as a way to understand your habits. It makes you aware of things.
Oh God, yes.
So you go, I don't like this stuff anymore. So I tell people to write it down. What are the things that you eat that bothers you? It's like, when I ate pizza, it just didn't sit well with me. Okay. I was like, write that down. And then when I went to the restaurant, how much did I eat? I ate this much. I had one glass of wine. That was all of it I needed. So I tell people those are the habits that you want to maintain, because the idea is, of course, if you want to be on GLP-1 at a lower dose or whatever, you can. But most people, they should get off it. And if they can put those habits in place, then it helps you to maintain and kind of go from there. Yeah.
Right.
So it helps you to modulate habit, because it's so hard. We all know what we're supposed to do, Yeah,
the approach I would like to take is, hopefully I don't. Hopefully by the time I'm, done having a baby or a couple babies, like I'm in my brain right now. I'm like, I can't wait till I can get back on one because I just felt so much better.
Yeah.
But no, I don't want to be on it long term forever. But I would like to do a lot of gut healing, because I think that's where the abnormal cellular response is coming from.
It's all coming from there.
Yeah, and also just sleeping more, modulating my stress. And I think if you can kind of control those three things, I wouldn't need it, because I would have the proper cellular response.
Absolutely. And GLP-1 also is good for the microbiome. So we know now that it works for the microbiome. People used to kind of have this other side of it. But you mentioned something that is very important, and I think people should really listen to that. And that's the idea of having gut issues and having stress. Okay. Mm-hmm. So when you're trying to fix gut and you don't solve stress, it never gets better. Okay. Because what's happening is anytime you stress, you have this gut-brain connection. You push cortisol into the system. It goes in there and then it wipes everything out. Okay. So all the work that you're doing, if you're still stressing, you keep wiping it out. Keep people like, because you can tell when you're stressed, you can even feel it in your stomach. Right? Yeah. That response is visceral. You can be aware of it. So it's really important that when people are doing gut protocols, to also bring in some adaptogens and some other things that helps reduce stress response, plus the lifestyle things, the meditation, the sleep, the breath work. All of that is really helpful for also helping heal the gut.
Yeah. I needed to hear that. I've been working on it's one of those things you're like, of course, but we don't think about it.
Yes, and it took me a while to which I've gone to this conference, I learned from people, and as a pain doc, the gut is so important. We talk about something called peripheral sensitization, central sensitization, basically principles that leads to how pain is processed. Okay. All of that is modulated in the gut.
Really?
All of that is modulated in the gut.
So do you do like GI map tests with patients?
I do GI map tests. I do gut Zuma with Vibrant, but I've done a lot of GI map testing, and it was just a game changer
Really?
People that have migraines. I actually had somebody who has a real diagnosis of migraine. This was very weird. One person, one case, we couldn't even get insurance to approve whatever Nortec, whatever he needs. And we're like, okay, his symptoms was kind of like all there's other things going on. And we check his gut, and he has some dysbiosis and some other bacteria. We treated that, and his migraine went away. Okay?
Really?
So that was the source of that trigger. So definitely the gut is one place that I would say if you have chronic pain, we definitely got to look at that.
Okay.
And more importantly, kind of look at what you put into the gut. Okay.
Right.
You know, sometimes, you know, people don't have access to those type of testing, but you can eliminate diet. Ask yourself, how do I feel when I eat this food? You know, we've lost the act of listening. Your body is always giving you the signal. Okay. And if people can just sit and be quiet, you would know what feels good, what doesn't feel good. Sometimes you wake up and you go, I don't feel good. What happened? I can't make good decisions. And it's because of something you ate. It's because of some, you know, environmental stresses. So the body keeps score. So it's really important for gut health for people to just listen after you eat. And that should be able to, you know, do a lot of the work. Beyond that, you know, come see me, go see a doctor, come see practices that understand these principles and try to kind of provide those directions for you as well.
Yeah. Do you see patients via telemedicine?
I do, yes. I see a lot of my patients are telemedicine. I do procedures, so people come in and we do specific testing, VO2 max, body composition, other type of procedures, ozone, prolozone, those things people come in. And then for the most part, we can do this in telemedicine so people can be at home and still get some guidance on how to optimize their health.
Are there certain states that if people live in those, they can see you via telemed or?
Yeah, so most states, because I've kind of moved away from the insurance model. I used to take insurance and it was not working. I mean, it's just... it's
an unfortunate truth.
It's unfortunate, but I'm coming to the place and recognizing people need to value their health. So with that, people can see me I have people from different states that will do telemedicine. And with advancement, you can ship testing to places, you can ship medicines and other things like that. So it makes it easy, accessible.
Wonderful, wonderful. Before we wrap up, I have a couple of rapid fire questions for you. Cold plunge or sauna?
Sauna.
Sauna?
Yes.
Both personally and for your patients?
Personally and for my patient.
Okay.
The evidence for cardiovascular benefit way outweigh cold plunge. Cold plunge, also, you know, a little bit of anabolic stress, like it shrink the anabolic growth. So when you exercise, you have all these myokines and they kind of slow things down a little bit. So definitely heat.
Heat. Okay.
Yes.
And do you like an infrared sauna or more of a traditional Swedish sauna, or do you have no preference?
No preference, but I think if you have both infrared, then you're getting more, right? Because the therapy, the red light therapy plus the heat itself is giving you extra things that are modulating mitochondria function. Yes.
Right. A little more detoxifying, which is nice.
And detoxification, which is really, really wonderful. Yeah.
Yeah. Yeah. Are you putting any of your patients on detox protocols?
I do. And a lot of it is, you know, drink a lot of water, get into the sauna, and then we can also do specific supplements that can help people with that process, optimizing kidney function, optimizing liver function.
Okay, wonderful. IV therapy or peptide therapy?
Peptides.
Peptides.
Of course, peptides.
Right.
IV is great, but IV is, you know, replenishing some deficiencies.
Right.
But peptides are modulating what the cells is doing. It's telling the cells to do specific function. It can restore, it can repair, it can resolve, and it can communicate. So definitely peptides.
It's a little more ongoing. IV.
More ongoing, yes.
Yeah, I feel like IV is great for, you know, acute. You need something kind of immediately, or we're going to do a protocol and do something once a week for a few weeks, great. But peptides you can do yourself all the time.
Yep.
What do you think is the most underrated hormone balancing habit?
I would say sleep.
Sleep.
Yes.
How much sleep do you recommend?
7 to 8 hours.
For both men and women?
Both men and women. I know there's some differences there, but for me, I
speak to a lot of men who are like, I function great on 6 hours of sleep. So
people function great on those, you know, there's been studies kind of looking at that, but when people get more, they actually get a lot out of it. Okay. So, and I think there's also different chronobiology. Some people have different, some people can function. So there's all this, I think there's a lot of nuances, but as a general rule, you know, we just say, okay, you know, I don't get 7 to 8 hours. Okay?
You don't?
I don't.
Okay. I love the honesty.
Yes. You know, so I think some of those things is, you know, people have resilience. There's all of these things that there's nuances in we are getting to precision medicine.
Right.
Some people can survive with certain stresses. Some people cannot do. So we're going to get to a place where we're going to figure out, okay, for you, maybe 6 hours is good for you. Okay. And then the thing is, we are also changing. As we age, the needs for specific signals changes, right? So, but definitely getting a lot of sleep is super important, because when you sleep, that's when you're making all the hormones. You're making your growth hormones, you're making testosterone, you're making estrogen, you're kind of making all of those things when you sleep.
Right.
Okay, so sleep, super, super important for hormone optimization.
Okay. That's good to know. Not to brag, but I got 9 hours last night, and
You did it.
I feel really good.
A+. Yes.
It was probably the first time in 6 months, but that's okay.
I had a drink last night, so I didn't sleep well. Yeah. I took my chances. But I knew what was going to happen.
Yeah. You had fun, and you had a little bit of stressor. It's good for you.
Yes.
Okay, what do you think is the most overhyped wellness trend?
I think supplements without any labs.
Yeah.
Yeah. Because your body, it has all this intelligence, and if it doesn't need something, you just put it in there, and we don't know what it's doing. And I think it's also for people to recognize. People tend to I don't want to take medication, but I'll take a supplement. Mm-hmm. So they are all plant derivatives or whatever it is, right? And what is natural does not mean it's safe, okay? Mm-hmm. And what is safe for me may not be safe for you, okay? Right? You're going through pregnancy, some other things. So you have to kind of consider all of those things. So I think we need to make things a little bit more specific. Yeah. And then it's also all of the things that people take. I take a lot of supplements too, but I pause and I kind of check labs and see what I need, because all of that have to get metabolized by your liver. Mm-hmm. Whatever it is you put in there, your body have to kind of find a way. And then we also know a lot of these things have toxins in them, and so I would say yes, that's a trend that we got to pay attention to.
Yeah. I talk to a lot of people because I'll have friends ask me oh, what supplement should I be on for this? I bought this. There's lots of hot new supplements out there that are marketed very well, and a lot of them are even very clean. Yeah. But it just comes back to, but do you need that? Do you need this probiotic, or what do you actually need? Exactly. It does kind of feel like I love a great supplement, but at the end of the day, when you think about it, people are just selling the magic pill. Yeah. It's it's not. Are you looking for and almost everything is, are you looking for energy? Yeah. To lose weight, vitality. Right. Yeah. Or to lower your stress. It's it's hitting one of those three things, and it's it's the magic pill. Yes. It's the fundamentals. Get good sleep, eat well, exercise, and then maybe a supplement here and there. But I think it's a trend that's overblown because it's marketed well. Yeah. Well, my next question was sleep or supplements, and I think we're going to go sleep. Oh, yeah. For sure. Do you drink coffee or matcha? I would say at this moment, I would say matcha. I mean, it's less caffeine, and it has some other benefit and modulating, calming you down. Yeah. But sometimes I also like coffee for, a little bit of a stimulation. Yeah. I'm the same way. I'm usually matcha, but I have coffee in there. Yeah. I usually do a matcha in the morning. And then if I need something in the afternoon, sometimes it's coffee for whatever reason. So why do you do that way? It makes me anxious if I drink it in the morning. Interesting. Because cortisol? Have you checked your cortisol in the morning? Yeah, it's very low. Okay. So I need something. Okay. But the matcha makes me feel good. I notice the coffee makes me feel anxious. And I think because if I've eaten more, the coffee makes me less anxious. And I try to take theanine with it as well, so that it kind of helps. Which matcha has. Balance. Right. Yep. Which matcha has already. What is one therapy you personally can't live without? Say peptides. Peptides? Yeah. Do you have any that you'd like to share that you use personally? Yeah. So I use CJC epimoreline. You do? I love thymosin alpha-1, thymosin beta-4 for the immune modulation benefit. And I also like epitalon. Have you explored epitalon before? I haven't personally done it. My dad has been doing it for years, though. You do what is it? It's like a 10-day cycle once a year. Yeah, so you do that, and the epitalon for me, the experience I have is one of those things that kind of stimulates your pineal gland, right? It's kind of high up, so I feel very calm and very tapped in. It kind of has this effect on me where I just feel very calm and everything is clear. Oh, yeah, that sounds nice. Yep. So it's a good feeling. Okay. I've not done GLP-1s. I definitely want to explore some, my sugars. I have some genes that predispose me to, sugar dysregulation, even though I don't eat any of those things. So I think at some point I'm going to do some low doses of retatrutide, something like that. Oh, yeah. To see how I do. Yes. Yeah. My dad's been exploring with retatrutide and he really likes it. One word you would use to describe the future of regenerative medicine? Transformative. Transformative. Yes. I love that. Yeah. Yeah. Where can people find you in your practice? So we are in Wayne, a suburb of Philadelphia, and the name of my practice is Ether Medicine. So Ether Medicine, people can go to our website, www.ethermedicine. It's AETHER medicine. People can also reach out. They can call us 484-806-1101. And I'm excited to connect with people, give them guidance. I think there's so much unnecessary suffering from pain. There are solutions. And you have to find a provider who understands that. And I've spent my time in the last 4 years
having had all this great training, I went to Hopkins, I went to Harvard, I have this strong basic foundations. But what really is changing what I'm doing now is the patient who's stuck in pain not getting better, low energy, hormonal dysregulations. So then it have pushed me to learn how to solve those problems. So we are happy to connect with people, and people can also follow us on Instagram, ether_medicine.
Love it. Yes. I was going to say, you're making great content on Instagram, so people should follow you there.
Yeah, I do a lot of education when I get out there, and I try not to structure too much, but I get out there and talk about stories and how we can impact people's life. Yes.
No, I think, like I said, it's, you're sharing a lot of really valuable information. I don't see anyone else sharing information, especially about migraines, the way that you are. So thank you for what you're doing.
Thank you so much for having me. Yes.
This podcast was brought to you by Pureform, a comprehensive wellness center in Boca Raton, Florida. The website is pureformhealth.com, or you can find us on Instagram at pureformhealth. Feel free to message us with any questions, and note that you can connect with our providers for consultations over Zoom, from everything from stem cell therapy to hormone replacement therapy and peptide therapy. That's it for this episode of the Healthspan Collective. We hope you found it insightful and inspiring. Don't forget to follow us wherever you listen to podcasts so you never miss an episode. And if you enjoyed today's conversation, we'd love for you to rate, review, subscribe, and send it to a friend. We'd also love to connect with you on Instagram. Follow the podcast at Healthspan Collective and me at Nicole J. Doran. And leave us a comment on our latest post, letting us know what you'd like us to cover next.